Greetings, everyone, and good morning, good afternoon, or good evening, depending on where in the world you're watching from today. Thanks for tuning in to this Children and AIDS Learning Collaborative webinar, which brings a summary of the newest science and the newest learning on children, adolescents, pregnant women, and HIV that was presented at the International AIDS Society Conference on HIV Science and the annual HIV Pediatrics Workshop that both took place back-to-back between the 16th and the 21st of July. My name is Rikke Lee Kirkegaard. I manage UNICEF's Learning Collaborative on Children and AIDS, and I am honored to once again host this scientific webinar presented to you all by Dr. Lynn Moffinson. Dr. Moffinson is currently working as technical advisor to the research program at the Elizabeth Glaser Pediatric AIDS Foundation. She was at the National Institutes of Health from 1989 until her retirement in 2014, where she was responsible for program planning and development and scientific direction of research studies and clinical trials in domestic and international pediatric, adolescent, and maternal HIV infection. So today we have 90 minutes for the webinar. The presentation will last just over an hour and then be followed by around 20 minutes for Q&A. And before we move on to the presentation, I would like to mention a few practicalities. First of all, the chat box is for comments and concerns. So send us a message there if you have any technical issues or any general comments, but make sure to select all panelists and attendees if appropriate, as the default is panelists only. Second of all, if you have a question to the speaker, you can send it through at any time using the Q&A box only, and we will get back to your question after the presentation. Please note that we may not answer any of the questions posted in the chat box, so please remember to select the Q&A box. And just a final note that the webinar is being recorded, and the recording and the PowerPoint, as well as a longer slide deck, will be made available online after the webinar on childrenandaids.org, where you can also find recordings of previous webinars and sign up for the Children and AIDS Learning Collaborative, so you'll be informed of new resources and future webinars as well. So without further ado, I will now hand over to Lynn.
Thanks, Rikke. Can you hear me?
Yes.
Okay. So I'm going to present some selected abstracts from the Pediatric HIV Workshop and from the IAS, both of which were virtual again this year. And what I want to do is start with an update on epidemiology. Mary Mahey from UNAIDS gave an excellent talk at the Pediatric Workshop. So first, if we look at the yellow bars on antiretroviral coverage among pregnant women, we can see that in 2020, 85% of pregnant women with HIV received treatment, but you can see in the purple arrow that there's been little expansion since 2015. And there are major regional differences, and almost a quarter of the women not on treatment are in Nigeria and a further 33% in West or Central Africa. If we then look at new infections among children in the red line, there were 150,000 new pediatric HIV infections in 2020, and you can see there's been minimal change in new infections between 2018 and 2020, and we have again significantly missed our target of 20,000 new infections by 2020. This will look at the causes of new child infections globally. And the primary cause in 43% was that the mother didn't receive antiretroviral therapy during pregnancy or breastfeeding, most often because she was not diagnosed. In a quarter of the women, the mother did not continue with treatment during pregnancy or breastfeeding. And in about another quarter, the mother newly acquired HIV during pregnancy or breastfeeding. And then finally, in about 9%, the mother was on treatment, but was not virally suppressed. Early infant diagnosis remains only 63% globally and is particularly low in West and Central Africa. In 2020, only 25%, and you can see actually decreased between 2019 and 2020, while in Eastern and Southern Africa, it increased over the same time span. And there's been a decrease in the number of children with HIV receiving treatment in 2020, despite the decline in the number of children with HIV. Only 54% ART coverage. And the number of children on treatment actually declined between 2019 and 2020, missing by 800,000 our target. Almost 2/3 of the 800,000 children not receiving treatment were aged 5 or more years. ART coverage in children, shown in blue, 0 to 14 years, was 54% and significantly lower than the 74% coverage in adults in yellow or orange. And you can see in almost all countries, pediatric treatment coverage is significantly lower in children in blue than adults, except for Lesotho, Kenya, and Eswatini, where the rates are about the same. Proportionally, coverage was lowest in children 0 to 4 years, 40%, and adolescents 15 to 19 years, 55%. And there's a major gap in reaching 90, 90, 90 in children compared to adults. And if we look at all children, only 59% know their status. Only 55% of all infected children with HIV are on treatment. And if you look at all children, only 40% are virally suppressed. That compares to 82, 74, and 67% for adults. And if we focus specifically on suppression in children or adults with known HIV who are on treatment, there's still a major gap with 75% suppression in children versus 91% suppression for adults on treatment. And this looks at the rate of deaths between 2010 and 2020. And you can see that reductions in AIDS-related deaths were steepest among children in orange, age 0 to 9 years, a 60% decline since 2010. But among adolescents in yellow, age 10 to 19 years, progress has been slower with a decline in only 37% over the same period. And you can see that since 2017, there's actually been little improvement in mortality regardless of age. There was a IAS virtual session that focused on 2025 targets, and we're moving from 90, 90, 90 to 95, 95, 95 in terms of knowing your status, being on treatment, and those on treatment having suppression. But for the first time, there are specific targets, including pregnant and breastfeeding women and children. So there's new targets here. So for vertical transmission, the orange circle here, 95% coverage to eliminate MTCT is the goal. And then for sexual and reproductive health in the pink, there's a goal for 95% testing for HIV, syphilis, and hepatitis B, and retesting for HIV in high burden settings. 100% of pregnant women with HIV should be on treatment, with 90% on treatment before the current pregnancy, 95% viral load testing for breastfeeding and HIV positive women, 95% early infant diagnosis, and 95% testing at cessation of breastfeeding. So this is a major challenge, but we should be up to it. So we've had all of these problems. So what might be some solutions to the problem? And the first is that there was a lot of new data on dolutegravir in children. So first, I want to just briefly get you to understand the design of the study. This is the Odyssey study, and the data from older children greater than 14 kilos were presented by Anna Turkova at CROI in 2021. And it was a randomized non-inferiority trial comparing dolutegravir versus standard of care in children with a median age of 12 years, starting first line Odyssey A, or second line Odyssey B treatment in 8 countries as shown, with the primary outcome being viral or clinical failure. And the results showed superior efficacy of dolutegravir with 8% less failure by 96 weeks than standard of care in older children. So they also evaluated young children, yet less than 14 kilos, enrolled in 3 weight bands for intensive PK. And this was not specifically powered for efficacy, but they looked at it regardless. And there were 85 children enrolled, as you can see by weight band, with a median baseline age of 1.4 years, 85% starting first line, 15% second line, with the standard of care treatment being lopinavir/ritonavir in most. And the median follow-up was 120 weeks, with only 5 lost to follow-up. And this shows you the results for viral or clinical failure by 96 weeks, dolutegravir in blue, standard of care in red. So if we look at the primary combined endpoint, 26% of those on dolutegravir versus 49% on standard of care had viral or clinical failure. And this difference was really led by viral failure, with a viral load greater than 400 in 19% of dolutegravir versus 37% of standard of care, whereas clinical events, WHO-4 or death, were relatively similar. And this Kaplan-Meier shows you the time to clinical or viral failure, standard of care in red, again, dolutegravir in blue. And you can see the difference between the arms only really first emerges after about 1 year on treatment. And this is a primary efficacy analysis where they combined data from the older and younger children. The primary analysis was a Bayesian analysis. And you can see that overall there was 11% less failure with dolutegravir compared to standard of care in all children in the Odyssey trial. And now this looks at the young children specifically, looking at the percent less than 50 or less than 400 in terms of viral load. At week 48, you can see that there's not a significant difference between the groups, but by week 96, a significant difference emerges, with 76% of those on dolutegravir less than 50 compared to 50% in standard of care in the younger children, and 91% less than 400 in dolutegravir versus 71% for standard of care, both statistically significant. And there was no difference in adverse events between dolutegravir versus standard of care in the young children. There were similar rates of adverse events and serious adverse events between the arms. Most of the grade 3 events were infections or hematologic and not related to study drug. There were 2 treatment modifying events occurring only in the standard of care arm, and 6 deaths, 2 in the dolutegravir, 4 in the standard of care. And this looks at change in total cholesterol from baseline. Remember, most of the standard of care children were receiving lopinavir/ritonavir, and you can see in red in the standard of care arm an increase in total cholesterol over time, whereas in the dolutegravir arm in blue, it has remained basically a straight line. So in summary here, dolutegravir was superior to standard of care in young children based on viral or clinical failure. And at 96 weeks, a higher proportion of children on dolutegravir were suppressed to either less than 50 or less than 400. Adverse events were similar, few treatment changes, all in the standard of care arm. And these data provide strong support for the WHO guidelines and for rollout in younger children starting first or second line treatment, and just emphasizes the need to expedite procurement of dispersible dolutegravir tablets for young children. This now looks at viral failure and genotyping results from the older children in the Odyssey trial, the 707 children from the original trial that we discussed. Here we can see viral failure by study arm in first-line treatment, Odyssey A, 7% dolutegravir, 19% standard of care. In Odyssey B, second line, 16% failure dolutegravir, 20% in standard of care. So the patients with viral failure were tested for resistance with the closest sample to viral load greater than 1,000 after failure. And earlier baseline samples were sequenced if major resistance mutations were identified to be able to determine the incidence of new mutations occurring during the study while on treatment. So this first looks at resistance in first line, Odyssey A. And the first thing that you can see looking at this graph is that there are no blue bars. There were no resistance mutations with failure of dolutegravir given first line. Whereas in standard of care first line treatment, which was NNRTI based, for those with viral failure, 93% had NNRTI and 62% had NRTI resistance without any PI resistance observed. Now we are looking at second line. And if we, in the second line in the standard of care was primarily protease inhibitor. And here on the left, we see the proportion of resistance overall in second line. And you can see now that the blue and the brown bars are relatively similar, and resistance with viral failure on second line was similar in dolutegravir versus standard of care for NRTI, NNRTI, and PIs, and I'll talk a little bit about INSTI in a minute. But more importantly, if we look at the proportion with new resistance that wasn't present at baseline, you can see NRTI, NNRTI, and PI resistance was only seen in the standard of care arm. In the dolutegravir arm, 4 of 22, 18%, had new second line integrase inhibitor resistance, and 3 of these 4 were on AZT3TC backbone. This looks at the type of resistance mutations, and as might be expected, M184V was the most common NRTI mutation. K65R was also seen. For NNRTI, K103N was the most common mutation. There were 2 PI mutations in 1 child on standard of care second line treatment. And here you can see with new mutations, there were 4 children on second line dolutegravir that developed 1 or more of 3 integrase inhibitor mutations. And this looks at time to resuppression, which is the solid line, and time to switching in the dotted line in children here. So about 15% of children in standard of care in the dotted line switched regimens by week 48, 30% by week 96, and there was no switching with dolutegravir. A high proportion of the children with viral failure resuppressed. Now we're looking at the solid line after viral rebound, even without treatment switch. And this was marginally better in the dolutegravir arm, 58% versus 42% resuppression by week 72. So these data show us that dolutegravir has very high genetic resistance barrier in children. And in children failing first-line treatment, no post-failure resistance to any drug class was seen. Among those on second-line treatment, there was no new NRTI, NNRTI, or PI resistance, but 4 children did develop new integrase inhibitor resistance. A high proportion of children resuppress after viral rebound without treatment switch, with higher rates of resuppression in the dolutegravir arm, but I will note that none of the children with integrase inhibitor resistance had resuppressed by the end of the trial. So these data support the use of dolutegravir for both first and second line treatment, but ongoing adherence support is clearly needed, especially if the child is on second line dolutegravir to avoid the development of integrase inhibitor resistance. This now looks at weight gain and change in BMI. So at baseline, only 5% were overweight and 1% were obese. And again, we're talking about the older children trial. And you can see the standard of care anchor drugs were NNRTI, efavirenz primarily first line, and lopinavir ritonavir primarily, atazanavir ritonavir in second line. And the NRTI backbone was abacavir 3TC in most. So this looks at change from baseline weight and height. And you can see that the dolutegravir is in blue and the standard of care is in red. There are small additional gains from baseline in both height and weight in dolutegravir compared to standard of care. And at 96 weeks, the mean added weight gain in dolutegravir was 1 kilo and gain in height was 0.8 centimeters. And these differences occurred early and stabilized. And here you see similar data for BMI and BMI for age, small additional gains from baseline with dolutegravir. At 96 weeks, the mean additional gain in BMI was 0.3, and the differences occurred early, and the gap between the arms did not increase with time. The differences were similar whether you looked at first or second line, by sex, by age, and by NRTI backbone. 4%, 25, were newly overweight or obese at 96 weeks, but it was similar in both arms, 4% dolutegravir, 3% standard of care. So children grew better after starting dolutegravir, and differences between the arms in weight, height, and BMI were small and stabilized, and few became newly overweight or obese. And they concluded dolutegravir-based treatment was not associated with excessive weight gain in children. Now, there were data that were a little bit dissimilar reported from Tanzania. And this was a retrospective study of 229 adolescents on dolutegravir treatment for greater than 6 months, with most of these switching from another treatment regimen, and the majority had viral suppression. And they compared weight before the dolutegravir switch visit and 6 months after the dolutegravir switch visit. And at baseline, 98% had normal BMI for age, and only 1.7% were overweight. So after 6 months, 90% of youth gained weight, although only 18% gained greater than 6 kilos. And the percent of youth that were overweight increased from 1.7% before dolutegravir to 8.3% after being on dolutegravir for 6 months. So in contrast to the Odyssey randomized trial, in this study, there was an increase in the percent of overweight obese adolescents after 6 months on dolutegravir, but of course there was not a control arm in this study. So I want to move to talking about how well are we doing in terms of ART optimization, dolutegravir transition, and viral load implementation. So this was a study from Kenya that looked at the effect of family-centered care on viral suppression. So they compared pre and post valuation of viral suppression in children 2 to 9 years before and after family-centered care model intervention. And this included family caregiver literacy sessions, peer educators, psychosocial support groups, ART optimization, and linked to OVC support programs. And this was implemented at 8 sites. And you can see there was 69% suppression before, 83% suppression after, and after adjusting for age and sex, children in the post-family care period were twofold more likely to be virally suppressed compared to those in the pre-family care period. I liked this model. This was a virtual pediatric optimization toolkit that was put to support pediatric treatment optimization in Malawi. So to facilitate transition despite COVID-19 restrictions at 120 facilities, they established family treatment days to facilitate phone contact by the clinicians and encourage guardian peer-to-peer support, and created this toolkit for clinical and lay staff via email and WhatsApp using voice notes, video, Google form quizzes. For example, they had an educational video on lopinavir granule administration so that busy staff didn't have to interrupt during clinic to instruct people, gave accurate and consistent messaging, and allowed repeat viewing by both guardians and clinic staff. Through WhatsApp, they had a case-based self-study for clinical mentors to orient and reinforce optimization strategies. And they developed a decision-making tool to guide ART transition, recording the child's data, and experienced clinician mentors provided clinical action guidance by phone. And this shows you the proportion of children on optimized pediatric treatment before and after. And you can see the percent of children on optimized treatment increased from 29% in December 2019 to 93% by December 2020. And they noted that this toolkit and family treatment days were easily implemented at scale to facilitate identification and consultation on complex cases for pediatric treatment optimization. This was a study looking at rapid viral load to optimize viral load monitoring in Uganda. And it was a pre and post cluster randomized trial looking at differences in differences analysis. So they looked at both non-high risk adults and then 4 high-risk groups, including the ones we're most interested in, pregnant and breastfeeding women and children and adolescents. And 2017 to 2018 was the pre-intervention phase. 2018 to 2020 was the prospective intervention phase, comparing 10 clinics randomized to the rapid viral load intervention, 10 to the standard of care, with the primary outcome being turnaround time and adherence to ordering, and secondary outcome viral suppression. So the rapid viral load consisted of 3 components of an intervention. The first was development of a viral load flow sheet tool that included last viral load, today's visits, whether viral load was ordered, as you can see here. They put in place Cepheid expert viral load testing in a hub and spoke models with 2 hubs and 10 clinics in 2 geographic regions, with specimen transport daily by motorcycle and results phoned in to the clinician. And then finally, they developed a viral load counseling script for different instances so that there was consistent and standardized counseling of patients. So there was a substantial reduction in viral load result turnaround time in the rapid viral load clinics pre-post compared to the control clinics pre-post in all subgroups, not just low risk, but in pregnant and breastfeeding women, children, adolescents, those who were viremic or those who had missed viral load. And this is showing you the reduction in days to result from pre to post period. The rapid viral load also had a significant improvement in viral load ordering, including in pregnant and breastfeeding women. And then finally, rapid viral load showed improved viral suppression, including in children, but not pregnant and breastfeeding women. But I will note that they had a very high rate of suppression to begin with. But overall, you can see suppression was 76% in control versus 83% in intervention. So a promising intervention to speed up viral load testing and suppression. This is another example of a program that looked very promising for children with high viral load during COVID-19. They implemented in Kenya a phone-based virtual enhanced adherence counseling and daily treatment reminders at 18 facilities and evaluated 3-month viral load. So they had a standard of protocol, training of healthcare workers, provided phones, written consent from caregivers, and they had phone alarms aligned for the clients and case managers to the time of taking medicine, and case managers conducted daily calls to confirm drug intake. And adherence counselors called caregivers every 2 weeks to provide virtual enhanced adherence counseling. And you can see these are the results from 3 months after intervention. It was highly acceptable, 80%. Excellent retention. Viral resuppression was 67% within 3 months. And they considered this for further scale up of the program for management of children with viral failure. So this was a study in Tanzania that was a retrospective cross-sectional review of program data from 325 facilities in 5 regions in Tanzania to assess transition to optimal regions, optimal ART regimens, including lopinavir, ritonavir if you're less than 20 kilos, dolutegravir greater than 20 kilos, and viral suppression in children. So if we first look here, the trend in proportion of children on treatment by regimen within 2 years between June 2018 and June 2020, the percent of children on an optimal regimen, dolutegravir or lopinavir, increased from 9% to 86%. And this shows you viral suppression on the right. Overall, it increased from 60% to 83% over the same time period. And I will point you to the fact that viral suppression was lower with lopinavir-based regimens, 76%, compared to dolutegravir-based regimens, 89%. So we may see added benefit once dolutegravir becomes available for young children instead of lopinavir-ritonavir. This study looked at dolutegravir transition in Mozambique. And over 3,000 HIV-positive pediatric patients over 5 years on treatment at 16 facilities. And it was a clinical record abstraction from children and adolescents receiving services at the start of the new treatment optimization guideline implementation with rollout of dolutegravir for children over 20 kilos. September 2019 to August 2020, with the data collected in rounds to allow for ongoing data cleaning and analysis. And the first round looked primarily at switching. The second round looked at viral load response, and the third round is ongoing. So first, looking at switching. 80% of children switched during this time period, but you'll note that many children had more than one switches, 27% 2, 8% 3, and 3% had 4 or more switches. Of those who switched, 81% switched to a dolutegravir-based regimen within 6 months. Most of these from NNRTI, but a number from PI regimens. However, 16% of children that switched to a dolutegravir regimen then switched again to other regimens within 6 months, either NNRTI or PI regimens. At the last visit, 74% of children were on dolutegravir, including those who switched and those who were on dolutegravir for the full 6-month follow-up period. So why was there so much switching? So at least 5 out of 16 sites reported stockouts of dolutegravir 50 milligram tablets. And sometimes this reflected broader stock shortages at the province or national level. And 15% of kids who switched to dolutegravir and then switched back had a recorded weight of less than 20. And so the providers may have course corrected because less than 20 kilos were supposed to be not eligible for dolutegravir. However, not all children had weight data. So now looking at the second round viral load analysis, over 1,100 children were on continuous dolutegravir for 3 or more months with a median of 11 months. Of these children, 1,085 had viral loads available after 3 months or more on dolutegravir, a median of 7 months, and 998 had both pre and post dolutegravir viral load available, which is what this concentrates on. And if we focus on undetectable to less than 50, pre-dolutegravir, it was only 42%. Post-dolutegravir, it was 71%. So very good suppression post-dolutegravir transition. And this study looks at the CPAC model to look at the impact and cost effectiveness of viral load testing to inform transition. So there is a lot of debate about when you have a child who's on a regimen and they're failing, whether you need to do a viral load prior to switching them to determine what the backbone NRTI will be. And so they looked at 3 different strategies. Children are on, they're aged 8 years, they're on abacavir 3TC efavirenz, and there's no change. They continue on their current treatment till their failure, and then they switch to PI-based treatment. The second strategy was to transition all children to dolutegravir without viral load testing. So here we have about 30% failing on efavirenz-based treatment, 70% suppressed. They all switch without viral load testing. And then depending on why they had failure, they had different rates of efficacy. And very good efficacy if they were suppressed and changed. And then finally, we had transition with a viral load-based switch. So the children were on abacavir 3TC efavirenz. They had a viral load test. They had to wait 3 months for results. If there was viral load failure, they were switched to AZT 3-TC dolutegravir. If they were suppressed, they stayed on abacavir 3-TC and switched to dolutegravir. And again, efficacy depended on the reasons for prior failure. And this shows the results of the analysis. So if we look at clinical outcomes, life years, both dolutegravir strategies, dolutegravir here alone without viral load testing in green, dolutegravir with viral load testing in purple, both of these had better life expectancy than no change to dolutegravir. And dolutegravir plus viral load testing had a lower life expectancy than switched to dolutegravir without viral load testing. So here without testing, 39.43, with testing, 38.95. And this was mostly due to lower efficacy of twice daily AZT switch associated with the viral load testing strategy when you change the backbone. Looking at cost, both dolutegravir strategies had cost savings compared to no dolutegravir. Dolutegravir without viral load testing gave you more life years at a slightly higher cost than dolutegravir with viral load testing. And it resulted in dolutegravir without viral load testing being the preferred strategy with an incremental cost effectiveness ratio of $850 per life year saved, well below the threshold of $3,000 per life year saved for South Africa. So transition to dolutegravir, again, was shown to improve outcomes and save money regardless of use of viral load testing to select the backbone. Results related to the viral load testing depended on two things: the effectiveness of AZT compared to abacavir and delay in time to return for viral load results. And in sensitivity analysis, if AZT was at least as clinically effective as abacavir, then dolutegravir and viral load testing became the preferred strategy. And if the time to receive viral load results was less than 1 month, like if you did point of care testing, then again, dolutegravir and viral load testing became the preferred strategy. So this shows us if viral load testing is being used to guide transition, the use of point of care or other strategies to improve return time should be implemented. And clearly the long-term data on the efficacy of dolutegravir in combination with different NRTI backbones needs to be collected as dolutegravir rollout in children occurs. So I want to discuss a little of the abstracts on adolescents. This was a study from Thailand that looked at rapid initiation of treatment. So this used the Thai National Treatment Database and National Death Registry data to assess treatment outcome in over 19,000 HIV-positive youth initiating an NRTI-based treatment. And they classified these youths into 3 categories based on timing of treatment post-diagnosis. Rapid was you started treatment less than 1 month, intermediate was 1 to 3 months, and delayed was greater than 3 months. And this shows you the results. And if we first look at the graphs here, rapid treatment is shown in blue, intermediate in orange, delayed in green. And you can see that the proportion with viral failure over time and the proportion of switching over time was least with rapid ART less than 1 month. And here in the graph, we see the proportion of study outcomes showing us basically the same thing. The time to first viral load being suppressed to less than 50 or less than 200 was highest in the rapid arm. Viral failure after ART initiation, again, was lowest with rapid treatment. Switching was lowest with rapid treatment, and death and loss to follow-up were basically similar. And this just shows you the same thing here. No difference in death and loss to follow-up. This was a study looking at how to optimize treatment and achieve viral suppression using what they called RISE, Reaching Impact, Saturation, and Epidemic Control in Nigeria. And so this was implementation of a multidisciplinary intervention for over 4,600 adolescents in 103 facilities in Nigeria. And they compared regimen optimization, viral load testing and suppression, 6 months pre-intervention, and 6 months post-intervention with a chart review. And the intervention was multi-strategy based. It was adolescent-based case management, peer-to-peer support, behavioral interventions to identify and address age-specific barriers, with add-ons such as free Wi-Fi and games to improve adherence to clinic appointments, and capacity buildings both for the healthcare workers, but also for the caregiver. And this just shows you visually the different things that they put in place. And here we see the percentage receiving optimal regimen by age with a viral load result, and then with viral suppression, with pre-intervention shown in blue and post-intervention shown in orange. And it's pretty clear just looking at these charts that there was a superior response in terms of receiving optimal regimen, getting a viral load test, and being suppressed. So adolescent-specific program and capacity involvement of youth in their care resulted in improvement in commitment to self-care, and caregiver involvement in healthcare all worked to improve health outcomes among adolescents and young people with HIV. This was developing of a transition readiness tool. And this was 199 adolescents with perinatal HIV at their last pediatric clinic visit prior to transition in South Africa. And they administered a questionnaire, and then they evaluated associations with viral suppression 1 year after transition. And they used a youth behavioral risk survey, adolescent social support scale, self-esteem scale, and a readiness for transition scale called HEARTS. Factors associated with viral suppression 1 year post transition was firstly transitioning was being on first-line treatment, disclosing their status, having a higher transition score or positively correlated, alcohol use, age, and female had a negative correlation. So they then developed a scoring criteria and found that if you compared a low score versus intermediate to high score, this was highly sensitive and had a high negative predictive value. If you had a high and you compared that to intermediate to, that should be low, high specificity and high positive predictive value. So they concluded a high readiness score meant that the child was likely ready to transition to adult care. An intermediate score may benefit from additional time in the pediatric clinic and some additional interventions before transition. And a low readiness score, less than 2, should have additional time in the pediatric clinic and additional interventions prior to transition. This was a study that looked at the dapivirine ring, which, as you all know, is now recommended as a choice for prevention of HIV for women by WHO. So this was a randomized open label crossover study looking at the dapivirine ring versus oral PrEP in 247 negative adolescent girls in South Africa, Uganda, and Zimbabwe. And so they either started with the ring and then switched to oral PrEP, or started with oral PrEP and switched to the ring. And this is the focus of this analysis. And then they had the person could choose what they wanted in the last 6 months, and that is pending. So in terms of safety, 54% had 1 or more adverse events with no difference between dapivirine ring and oral PrEP. No adverse event related product holds, discontinuation, or related serious adverse events. This looks at adherence to the ring in green, to oral PrEP in blue with high use as shown here, and more than 50% were highly adherent over 12 months. Acceptability in, again, the ring here, oral PrEP here, acceptable in green. And more ring patients felt the ring was acceptable compared to oral, 88.5 versus 63.9. And this looks at compliance, and more were fully compliant to the ring, 50%, compared to being fully compliant to oral PrEP, 22%. So adherence to the ring and oral PrEP was higher than anticipated in African adolescent girls and young women. This is probably one of the highest 12-month rates I've seen. Both well tolerated, highly acceptable, and it shows that adherence to both can be achieved with tailored adherence support. Moving on to talk about PMTCT cascade and antiretrovirals in pregnancy. This study was from Uganda, and it showed us the importance of surveys to look at mother-to-child estimates. So they triangulated early and final MTC rates from 4 different sources. MTCT data routinely reported to the Uganda Health Management Information System, Uganda FIA, Population-Based HIV Impact Assessment, National PMTCT Impact Evaluation, and Annual Spectrum Modeled Estimates. And this shows you the results for early transmission and final transmission. So you can see that the blue line is here is spectrum, the yellow is the PMTC impact, the orange is the routine data, and the green is the FIA. So all data showed a marked decrease in mother-to-child transmission over time, although early and especially final rates differed by method. But the Uganda FIAs demonstrated the strength of population-based surveys because the FIAs capture the higher mother-to-child transmission rates among HIV-positive women who do not access care, and therefore they're not represented in these program data. The facility-based data demonstrated reassuringly low mother-to-child transmission rates even among lower-level facilities. But again, you can see the difference between the FIA rates and the rates that really measure only women who are in care. These were data from Lesotho looking at HIV-free survival in the era of treatment. And this pooled data from 2 Lesotho cohorts, the PWIL study and the IMPROVE study. And the PWIL study evaluated the effectiveness of the PMTCT program at 13 facilities, was a prospective observational cohort followed for 24 months. IMPROVE study was looking at a multidisciplinary integrated management team intervention, 6 facilities in a different district. Was a randomized trial and again followed 12 to 24 months, and the time periods had some overlap. So this looks at transmission, death, and HIV-free survival by study and overall, and I'll just look overall. So 2.4% infected at 12 months. Death was 9.5%, and if you take away stillbirths here, it was 6.1%, giving you an HIV-free survival at 24 months of 92.1%. And this is the Kaplan-Meier curve of survival probability. And the most rapid decline in HIV-free survival occurs between birth and 6 months and plateaus at about 1 year. They also looked at factors associated with HIV-free survival, older age of the mother, being a term baby, breastfeeding, and disclosure were all associated with improved HIV-free survival. So young age, preterm, no breastfeeding, and non-disclosure were associated with poor HIV-free survival. And here's another HIV-free survival study from Tanzania. And this was a prospective study of pregnant women starting option B+ between 2015 and 2017 in Tanzania. 47% of women were on treatment preconception. You can see that there was a significant amount of missing data. 1.7% of infants were HIV positive at 18 months. 3.3% died, giving an 18-month HIV-free survival of 95%, not that dissimilar from Lesotho. And they also looked at factors associated with the odds of HIV-free survival, finding the time of entering ANC, advanced HIV disease, the timing of treatment, and clinic volume were all associated. So those who entered ANC later, had less HIV-free survival, advanced disease, less HIV-free survival. If you started treatment before getting pregnant, then you had better HIV-free survival compared to those with very short duration of treatment, and higher clinic volume had better HIV-free survival. This study looked at HIV point-of-care viral load testing to identify high-risk infants in Mozambique. It was a part of an ongoing study evaluating point-of-care viral load. Viral load at birth significantly correlated with mother-to-child transmission at age 12 weeks, and they then looked at factors associated with lack of suppression at birth to identify characteristics that might be associated with increased risk of mother-to-child transmission. So risk factors for lack of maternal viral suppression at birth were younger age, here in red, lower education level in green, lack of HIV disclosure, as shown in the other studies, and more recent HIV diagnosis. This was a study from South Africa that looked at more frequent viral load testing with point of care. And so it was a 9-blinded study, and it compared point of care viral load testing here in green every 3 months to standard of care viral load testing every 6 months in HIV positive postpartum women on first line treatment, and then evaluated viral suppression at 6, 12, and 18 months to see whether there was any difference if you were doing more frequent testing. There were no significant differences at baseline between the arms. 57% were at preconception treatment, and at enrollment, 88% were less than 200 copies per ml, 91% were less than 1,000 copies per ml. And there was a significant loss to follow-up in this study, 36%. So when they compared viral load less than 1,000, baseline 6 months, 12 months, and 18 months, and less than 200, they found no significant differences in viral suppression between every 6 months standard of care compared to every 3 months point of care viral load testing. And you can see at 18 months, less than 1,000 was 94% in both, less than 200 was 85% in both. But there are 2 caveats here. First was loss to follow-up in the study, but the second is that the viral suppression rates in both of these groups were very high. 91% were suppressed to less than 1,000. And so the ability to be able to detect a difference with this sample size is likely relatively limited. This came from the PROMISE study and looked at the association of self-reported adherence with viral suppression. So they looked at the postpartum component of PROMISE, where women were randomized to triple ART, or the infant was randomized to infant nevirapine. So triple ART with only 6 weeks of infant nevirapine versus infant nevirapine for the duration of breastfeeding. And they looked at self-reported adherence to both. Self-reported adherence to study drug was lower in the maternal ART arm compared to the infant nevirapine arm. So reporting no missed dose within 6 months was 66% with maternal treatment, and only with 84% with infant nevirapine. And maternal self-reported adherence in the maternal treatment arm was associated with viral load. And if they reported missing 1 day of treatment in the 3 days prior to study visit, there was a 58% higher risk of having a viral load greater than 400, 66% higher risk viral load greater than 1,000. So in this study, the self-reporting was a reasonable measure of adherence. And interestingly, that the mothers were less adherent to their own treatment than they were to giving infant treatment. This study looked at progress towards 95, 95, 95 targets in South Africa using national antenatal HIV sentinel surveys conducted in 2017 and 2019. So if we compare 2017 to 2019, we can see that the first 2 targets, knowing status and receiving treatment, both met the 95 targets by 2019. But the third, viral suppression, target really wasn't any different between 2017 and 2019. And 34% of all HIV positive women were not suppressed in 2019. And they then looked at factors associated with viral suppression, defining it as less than 50, younger age, certain provinces for ANC care, and starting during pregnancy compared to before pregnancy were all associated with less viral suppression. This is a study from Malawi, a case control study that looked at factors associated with recent infection in pregnant women. They did baseline HIV testing with a validated algorithm for recency to over 400 HIV negative women enrolled in a behavioral intervention trial in Malawi, finding that 11%, 44 women, were found to have recent cases. And women with recent HIV were compared to 350 HIV negative women presenting in the same study. And they looked at factors associated with recent infection. And these factors included a positive syphilis rapid test, a partner being HIV positive or having an unknown status, being unmarried, and interestingly, overnight travel in the past 6 months for either the woman or her partner. Briefly moving on to HIV testing and case finding, there was an interesting presentation from the Population HIV Incidence Assessments, the PHIAs. And they used data from a national household 2015 to 2017 surveys from 6 countries to be able to estimate the proportion of children aged 1 to 14 years with known diagnosis versus unknown diagnosis at the time of the PHIA. So of 521 children living with HIV, 355 or 61% were known at the time of the PHIA, and 166% or 40% were undiagnosed prior to the PHIA, with the highest proportion of undiagnosed children aged 1 to 4 years, as you can see in the graph here on the left. And you can see on the right that this proportion varied by country and by age. So Eswatini and Lesotho had the lowest proportion of undiagnosed children, whereas Tanzania and Zambia, 50% or more of the children were undiagnosed. Children with undiagnosed status were more likely to have a mother with unknown status or have the mother diagnosed during the PHIA survey as well. 55% of undiagnosed versus 10% of diagnosed. And if we look at receipt of treatment, 88% of children with diagnosed HIV, that in green, were receiving treatment. However, when you include the undiagnosed children, only 54% are at coverage, worse among children 1 to 4 years with variation by country. So here we look at the proportion diagnosed versus all children on treatment. Here we have diagnosed children. Here we have all children. If we only look at the diagnosed children, we can see over 88% had antiretrovirals detected in their blood, compared to 40 to 50% in all children when you look at those who were undiagnosed or diagnosed. And similarly, you can see that the proportions varied by country. This looked at the impact of a community health worker administered index case testing screening tool on pediatric case identification in Malawi. So they developed this case screening tool, as you can see here, a very brief index case testing screening tool that was administered by community health workers. And they compared women screened, child HIV testing and results, and HIV positive children, comparing pre-intervention to post-intervention. So in this intervention, if an untested child was identified, they were invited to bring the child in for a test. The lay counselor identified barriers, improved access to testing, and then the tool was reviewed with the mother on subsequent visits to update the status of the child. So the case screening tool followed the mother. So 26% of women who were screened had at least one untested child. Of the over 60,000 children identified, 23% were untested. Using the tool, 55% of children with unknown status were tested by the mother's next treatment visit, with 5% new HIV positive diagnoses identified, with the highest yield in 1 to 2-year-olds. Moving on to pediatric care and HIV-exposed uninfected children. This comes from an infant tuberculosis prevention study, the ITIPS trial, where they compared INH prophylaxis in HIV-exposed uninfected infants to no INH prophylaxis and looked at the rate of MTB infection. So this is the initial trial, and what they did here was they did follow-up for 24 months to look at factors associated with MTB infection by age 2 years. So this looks at the incidence of MTB infection per 100 patient years, overall in gray, no INH in purple, and INH in green. So during the trial, there was not a significant difference between the regimens, but the rate of TB was lower in the INH arm, but you can see during extended follow-up, it became actually the opposite. And again, no real significant difference between the arms. And they looked at correlates of 24-month cumulative TB infection. And of all of the things they looked at, no running water was the only thing that was significant. So 24-month cumulative MTB infection was high in these HIV-exposed uninfected infants, 8.6% per year. Prior receipt of INH prophylaxis didn't decrease the incidence, and poor household conditions were what was associated with development of infection. This study looked at cotrimoxazole prophylaxis strategies, and it modeled 6 different strategies for cotrimoxazole prophylaxis in 5 African countries, including the current recommendations to start cotrimoxazole at 6 weeks and continue to the end of breastfeeding, 4 strategies that had shorter duration, 3 to 12 months, and 1 where only HIV positive children received, with the outcome being death between 6 weeks and 24 months. And this shows you their structure and their assumptions. So here we have HIV test at 6 weeks, postnatal transmission, HIV test at 6 months, HIV positive child started on treatment. And here are all the assumptions related to HIV transmission, having an early test, receiving a 9-month test, and risk of death. And references on the side here. So they evaluated the risk difference in mortality compared to no cotrimoxazole. So in all of the countries studied, the current strategy, which is shown in blue, provided the most benefit. However, if you compared countries that had high early infant diagnosis coverage and low mother-to-child transmission, such as South Africa, to those with low early infant diagnosis coverage and high mother-to-child transmission, such as the Ivory Coast, there was a difference. So in countries with high testing coverage and low MTCT, you can see the benefit with the current strategy is relatively small compared to the other strategies. So shorter duration of cotrimoxazole or only provision to HIV positive, that's the green, might be considered. Whereas in countries with low testing coverage and high mother-to-child transmission rate, the benefit of the current strategy is much higher. And this is due to the larger percentage of children with undiagnosed HIV and not receiving cotrimoxazole with the alternative strategies. And then this looks at Zimbabwe and just modified the model assumptions. Uptake of cotrimoxazole, mother-to-child transmission, rates of EID, mother-to-child. And while these modified the risk difference compared to no cotrimoxazole, they did not change these overall findings that the current strategy was the most benefit. This was data from a longitudinal study of HIV-affected children and their caregivers in 28 community-based organizations in South Africa and Malawi. And they looked at accelerators, which was defined as provision that positively affected child outcomes across 3 SDGs, with food security, cash grant, and safe communities being what turned out to be, most significant. And then they looked at 12 child outcomes and their association with these accelerators. And in brown, you see the child outcomes that they looked at. So they compared the presence of an accelerator with the outcome at a child. So if they first looked at association of the individual accelerators with decrease in adverse child and increase in positive outcomes, safe community, cash grant, and food security, you can see that there was improvement in a variety of different outcomes with each of these. When they looked at 2 combined accelerators, they found an additive value of having 2 accelerator provisions with further improved child outcomes. But they found that a combination of all 3 of these accelerators resulted in the highest probability of positive child outcomes and was superior to the provision of the individual components alone. So I want to, we're getting near the end, talk about COVID-19 related mitigation practices on programs. So 5 USAID and PEPFAR presentations at the pediatric workshop compared services pre-COVID to during COVID time periods in 12 to 14 African countries. And here you see the pre-COVID periods in brown, Q3 during COVID in green, Q4 during COVID in purple. So the first thing they looked at was services for pregnant and breastfeeding women before and during COVID-19. And so here we look at the change from Q1 to 2 to Q3, the change from Q1 to 2 to Q4, and then the change from Q3 to Q4. So you can see for all of these change in ANC attendance, HIV testing, and ART coverage, there were small initial early decreases from Q1 to 2 to Q3. But you can also see that these reversed by Q4, so improvement was seen. This looks at early infant diagnosis and linkage to care, and here they're comparing Q3 and Q4, dark blue and light blue. So EID testing volume and EID coverage were generally maintained with decrease in only 3 countries as shown here, but gains were less than the prior year. However, in HIV positive infants started on a linked treatment seen in 9 countries, there was a decrease. And the numbers linked to treatment decreased by 9.8% in fiscal year 2020. May have a relationship with what we saw in the UNAIDS data earlier. This looks at services to children living with HIV. And here we're comparing Q1, Q2 to Q3, and then change in Q3 to Q4. So the number of children aged 1 to 14 years receiving a test, started on treatment, and who received a viral load decreased in Q3 in all, with some to minimal improvement during Q4. The number of new HIV children aged 1 to 14 identified decreased significantly in both Q3 and Q4. But interestingly, viral load suppression paradoxically increased during COVID-19 in both Q3 and Q4, and we'll talk a bit about that in a minute. This looked at viral load coverage and suppression by age. Here you have viral load coverage and suppression for children 0 to 9 years and adolescents 10 to 19 years in green. And viral load coverage decreased slightly in children and adolescents and rebounded. Now here we're looking at Q1 2021. So by Q1 2021, it got better. And viral load suppression in the line increased in both children and adolescents, with highest rates of suppression among adolescents, 83 versus 77%. However, only 1 country, Lesotho, achieved the viral suppression goal of 95%, as you can see here by country. This looks at multi-month ART dispensing during COVID-19 in 12 countries. So here we see by country, we see Q1 in red, Q2 in yellow, Q3 in blue, Q4 in green. So across all countries, you can see that multi-month dispensing among children on treatment increased significantly during the COVID-19 pandemic. 3 to 5 months multi-month dispensing increased from 34% in Q1, Q2 to 45 to 47% in Q3, Q4. 6 months dispensing also increased 2.7% Q1, Q2 to 6.1% Q3, 9% Q4, although the overall coverage for every 6 months dispensing remains low. So if we look at all of these together, we saw initial declines in services during COVID-19, which improved as countries tried to adapt services to the COVID-19 pandemic. And it really shows the resilience of country programs to implement and scale up strategies to improve outcomes for children and youth, such as multi-month dispensing. However, of concern is the decrease in identification of older infected children, linkage of newly identified HIV-positive infants and children to treatment, and viral load coverage, all of which have decreased with only relatively minimal improvement. And just to comment that the observed improvement in viral suppression is likely biased, as those children who are less likely to be adherent to treatment may be also less likely to attend clinic and have viral load testing, with the testing then limited to those who are more adherent to clinic and testing visits. And additionally, we still have, as we know, a long way to go to reach suppression of 90 to 95% in children and youth. So I want to end just talking about adult studies, but that talked about long-acting treatment and PrEP options, because this will be relevant to children once they're studied in children. 2 drugs were presented. Lenacapavir is a first-in-class HIV capsid inhibitor, and it's given only once every 6 months subcutaneously. They presented data on the use of lenacapavir for treatment in ART-experienced multi-drug resistant patients and ART-naive patients, finding 81% suppression with optimized regimen background in ART-experienced patients with multi-drug resistance, 94% suppression when given with FTAF in ART-naive patients, which was very similar to their comparison of an integrase inhibitor. So this is a highly promising drug that only requires being given once every 6 months, and PrEP studies in women and MSM and transgender women are planned. The other drug that was presented was islatravir, which is a first-in-class translocation inhibitor with multiple mechanisms of action. Here, islatravir is given orally once a month for PrEP, and it was a phase 2A study. It was well tolerated, mild AEs, no drug-related AEs, very rare toxicity at all. The drug levels in peripheral blood mononuclear cells remained above pre-specified PK thresholds for at least 8 weeks after the last dose. And PrEP studies in women and MSM and transgender women are planned. Again, a drug given orally once a month. And I think that is it. And I will stop.
Fantastic. Thank you so much again, Lynn, as always, for an excellent overview of the many scientific advances that have come out the last year. We now have around 15 minutes for Q&A. And as mentioned, we'll be taking all of the questions from the Q&A box. So please feel free to start sending in your questions. And if there are any general comments, please send them through the chat box. We will start with a couple of questions from Dorothy. Dorothy is asking, in the study from South Africa on readiness for transition, whether the timing of infection had any impact on readiness.
If I remember correctly, these were all perinatally infected youth. So I don't think that they looked at non-perinatal infection. but I'd have to go back to the study, Dorothy, to take a look. And the slides should all be available for you so that you would be able to take a look at them.
Okay, another question from Dorothy is, what are the key components of the tailored adherence support that worked for PrEP in adolescent girls and young women?
Yeah. So again, I think I would need to go back and look at those they had specific monthly phone contacts, if I remember correctly, was one piece. So they had, M-Mobile support that they provided, but I don't specifically remember the other things. If you take a look, you can access the abstract numbers on the slide from, I think it was at IAS. Thank you.
Thanks. And just a note on that, so a couple of questions also coming in around the recording and the slides. So the recording will be available within the next day or two on Children AIDS. We'll send out an email to everyone once it's been posted. And you can find the presentation slides as well as a longer slide deck on Children in Need. So everything will be available by tomorrow, more or less. Another question coming in from Shafiq on the study from South Africa on CTX prophylaxis. He says it seems to suggest the guidance should be changed, but ironically, the better programs with higher coverage of PMTCT and CTX needed the least.
Yeah, so the guidance was actually not changed, but there was some modification. I'm not using the right word, Shafiq, but with the latest WHO guidelines that were put out in July, they modified it to discuss the fact that there may be differences between countries, those with high EID and low MTCT, and that alternatives can be considered. In order to do a full guidance modification, PICO questions and a review need to be done. This was the beginning of that, but it was not a guideline change. It was really a clarification.
Thank you. There's a question that's come in from Nicole. She's saying, amazing, Lynn, as always, thank you very much. And then she has a specific question on viral load suppression for children. Do you think we will have to wait 2 years to see the impact on viral load suppression for children transitioning to the new pediatric dolutegravir 10 milligrams?
Yeah, I hope not. I think the data are really encouraging about increased suppression and increased suppression being seen quickly. If you remember the study from Michelle Gill in Mozambique, that was looking at a median of 7 months on dolutegravir with an increase to almost 80%. So I think if we can get our dolutegravir transitions underway, and in particular, if we can include those younger children, that we'll be able to see an effect more rapidly. So there was a question about what was most excited and made me the most hopeful. And it was those dolutegravir studies and dolutegravir transition studies. I thought that they were provided an answer to the somewhat discouraging data that we saw epidemiologically. That those to me provided the best answer. Let's get kids on dolutegravir of all ages, and hopefully we will see a big improvement.
And certainly I think we've seen the evidence really building for this. Perhaps in line with Jaime's question around what made you more excited and hopeful, can I ask, what are your key takeaways from this year's conferences?
Yeah, so I think the one key takeaway clearly is the efficacy of dolutegravir and the good programs that countries are putting in place to be able to increase this transition. And the fact that we are able to move to younger age groups is very encouraging. There were a number of programs related to both transition and adolescent care that I thought provided some interesting, potentially very effective models that other countries could put in place. And then the last thing I think was the resilience of countries dealing with COVID, that while there were decreases in some parameters, these were able to be reversed by countries that developed innovative new solutions to how to provide care when you have to have social distancing and masking. And hopefully that these innovations will be able to be then moved forward to non-COVID eras because they appear to have worked very well. So those are the things.
Thank you, and completely agree. I think we're already seeing some of these adaptations stay. Coming back to the CTX study that was discussed before, this question from Katie asking whether the investigators factored in or compared the impact in malaria endemic versus non-endemic countries, because she noticed that in the past that has been a factor.
Yeah, that was not done, I don't think, but a number of the countries that were in the low EID, high MTCT were also malaria endemic. So I don't think it was specifically done, although the mortality rates that were used may have taken that into account.
Okay. A question from Laurie. She says that she remembers that there have been issues with sample size in the FIA studies for various subpopulations. So what do you make of the very high MTCT rates that were found? And do you think that they are an accurate reflection of transmission at population level?
Yeah, well, I guess one comment I would make is that I thought that the FIA data showed how important it was to do these studies that were adequately sampling children and addressing that question. So I can't tell you right now in terms of the sample size for the FIA data that I showed you, because I don't believe that it was actually presented per se, but I do think it shows us that it's really important to, when we're trying to look at overall program impact, to be able to remember that you need to capture those people who are not in care if you really want to look at what is the true overall impact. So I do believe that if you include those who are not in care, that the mother-to-child transmission rates are going to be much higher, because those are the groups that the mother-to-child transmission rate is going to be high in, because they're not in care, they're not diagnosed, and they're not treated. They reflect what was shown in the UNAIDS data on, where is the biggest problem? The biggest problem is women are not diagnosed or they're not put on treatment. And so what the FIAs show us is that we're not capturing that in many of the ways that we're looking at things now. So I'd like to see FIAs for pediatrics funded more.
Very good point, Lynn. We have a few comments that come through the chat box, and one question in the end from Nia Weira on the impact of psychosocial circumstances and outcomes on long-term self-care and clinical outcomes. I mean, the IAS conference tends to be more scientific, but will you have any thoughts on this?
Well, there were presentations on this, and I did present some of them. The RISE study, for example, the study that looked at accelerators and outcomes. So I do think that there are studies out there. They may not just be presented at these meetings. I tried to pull out the ones that I thought were most valid to present here. They may be more likely to be presented at meetings like ACASA, which may be more clinically oriented.
And ICASA is taking place in December. So before long, we will be able to see some of the outcomes from that as well.
Yeah.
So I don't see any more questions. If anyone has any last burning questions, please send them through now. I see some conversation taking place in the chat box, which is great. But if there are no further questions, we can close the webinar. Again, if there are any other questions that pop up after the webinar, please send me an email and we will get back to you on that question. As mentioned before, we will post the recording of the webinar on childrenandaids.org in a day or two, and we will also make available both the webinar slide deck presented today, as well as an extended slide deck that covers a broader range of studies. So once again, I'd like to thank Dr. Lynn Muffinson for the excellent webinar and the attention to the questions asked by all of you. So thank you again for joining us today, and hope to see you on the next webinar.
It's a pleasure. Thank you. Bye, everybody.
Bye, everyone.
That went well. Congratulations, Rike.